In the first round, in our state, I think 3 lakh people are going to get vaccinated. It's going to start from tomorrow, actually.
That's good.
Yeah.
Sorry, Dr. George, I was just asking you which vaccine is preferred over there in Canada? Any idea which?
I think we have approval for the Pfizer and is it Moderna?
Oh.
Moderna.
But the Pfizer is the one that's being used right now. The problem with that one is that to store it, you have to store it at very, very low temperatures. I think it's minus 70.
Yes.
And so there's all the challenges with that.
That's right. So we are not going to get that because we'll never reach minus 70, across the distribution chain. So I don't think
the
we'll
cold
get
chain is
that.
difficult.
Yeah.
Yes. It's proving to be very difficult in Canada. They're using the military to do it. So what vaccine will you be using?
We have Covaxin. This is from the Serum Institute.
Okay.
So
it's nice to see that there's so many vaccines out there, though. It's very reassuring, and it's interesting how they all seem to take the same amount of time to make.
Exactly.
So
we'll go live in another 2 minutes.
Okay.
Hopefully I'll get my vaccine in the next couple of weeks, but they worry that even with the vaccine that if I travel, I still have to quarantine because they say I might still carry the virus and then still transmit it to people that don't have the vaccine.
Yeah, they're recommending you need to wear the mask still.
Yeah.
You will be protected, but you can still transmit the virus.
Yeah. I think in a way we're lucky.
USA is many people are getting vaccinated. So why is the delay in Canada?
I have no idea. I wish we were faster. I think part of it is that I believe we don't have any company that's making the vaccine in Canada. So we're having to purchase it from other countries. And I think, respectful country would give us some, but they're going to hold the majority until their own population is vaccinated. So that's one of the disadvantages. But we're also a very big country, but with a very small population, 35 million, but a huge country. So just even the logistics with the Pfizer vaccine, from what I understand, the logistics of transporting it that's one of the main issues also, and keeping it at its appropriate temperature.
Less density, they're spread across a huge area, so they may be challenging for the vaccine to be transported.
That's how things are in Canada. Things are never fast. We're a slow-moving country.
You're talking to Indians.
Hey, I consider myself Indian, so.
Right. It's an honor for us.
I'm sorry, I didn't hear that.
The webinar is now alive.
Oh, we're live?
We are live.
Yeah. Yeah. Can we start?
Yeah, people joining in now.
Yeah, Avinash, I think go ahead. We are live.
Right, sir?
So I welcome you all to the first webinar of this year, hosted by the Bangalore Orthopaedic Society. So first of all, Happy New Year to all of you. And a very early good evening to the listeners from India, and a very early good morning to Professor George Athwal from Canada. So Professor George Athwal, who will be introduced by Dr. Rudra Prasad, is a consultant shoulder and elbow surgeon from Canada. So he'll be conducting the masterclass on shoulder today. So I very warmly welcome him to this webinar. We also have Dr. Rudra Prasad, who's our moderator for the evening. And we have Dr. Hemant Kumar and Dr. Chetan Nagraj as panelists for the course. So, sirs, I welcome you all. I also welcome Dr. Naveen Thakkar from Gujarat, who's very actively involved in the academic proceedings during this COVID period. Welcome, sir. Yeah. So I request Dr. Rudra Prasad to introduce Dr. George Athwal and start the session. Thank you.
Thank you, Dr. Avinash. It's really a honor to introduce such a big man in the field of shoulder and elbow surgeries. And I was just going through, and in fact, I heard Dr. Athwal in Indian Arthroscopy Society webinars. Quite impressive description, and he's a great teacher. And definitely Bangalore Orthopaedic Society and Karnataka Orthopedic surgeons are quite lucky to have him on on teaching base today. So Dr. George Athwal is originally from Vancouver and completed his MD at the University of British Columbia. Following completion of his orthopedic surgery residency at Queen's University, he spent 2 years subspecializing in upper extremity reconstruction and trauma. He completed 1 year fellowship at the Hospital for Special Surgery, Cornell University, New York. And following this, he completed 1 year at the Mayo Clinic in Rochester, specializing in shoulder and elbow surgery. In 2005, he joined the Hand and Upper Limb Centers at the University of Western Ontario. He is actively involved in biomechanical and clinical research pertaining to the shoulder and elbow. Dr. Athwal has been awarded the Dean's Award of Excellence for his research contribution to the Chulich School of Medicine and Dentistry, the Clinician Scientist Award from the Department of Surgery, a Career Development Award from MOSO, and the HS Cameron Teaching Award. Additionally, he has represented the Canadian Orthopedic Association as a North American Traveling Fellow and also represented the American Shoulder and Elbow Surgeons as a European Traveling Fellow. So to his credit, he has over 250 scientific publications and 40 book chapters, and he's an associate editor for the Journal of Shoulder and Elbow Surgery and the Shoulder and Elbow Arthroplasty as well. So he's the immediate past president of the Association of Clinical Elbow and Shoulder Surgeons. Furthermore, he has been recognized by the peer as a leader in shoulder surgery. So there are plenty of things to tell about Dr. George, but will not take much time. But certainly he's a great human being, and and in fact, it's an honor for us to announce that he has a great roots in India. His both parents are from India, so it was a nice thing to know. I welcome Dr. George, and over to you now for your thoughts. Thank you.
Thank you so much for that wonderful introduction. Yes, I do consider myself Indian. Both my parents were born in India and moved to Canada in the 1960s, and so I've been to India for vacation and for work 8 times, and so I've always enjoyed myself, and it's always fun to go back. I wish I could be there right now, because in Canada you can't see outside, but it's very cold. It's 6 a.m. in the morning, and I'm sure the weather's a little bit warmer where you are. So I'm going to share my screen here. I hope it comes through. Can everyone see my screen? I'll switch over to my presentation.
Yes, we can.
Great. So, so today we're going to spend some time talking about shoulder instability. And for the next hour and a half, I've got 3 presentations prepared. The first, we're going to talk a little bit about complex shoulder instability. I think we all know how to manage what I would say is simple shoulder instability. We're going to talk about how to identify which patients that we have to escalate the operation, maybe do more than a simple procedure. Then I'm going to talk a little bit about one of my research interests, which is the arthroscopic Latarjet. But we all know that if you listen to the people speak, that the Latarjet is supposed to be one of the best operations out there, but it does have problems. And then we're going to spend the last little bit talking about all the things that can go wrong with the Latarjet and how we may be able to manage them. And so I'll get started. So well hit. Is the slides projecting well and coming across? They're okay? Okay. So really, we're going to go through some of the background of shoulder instability. The most important topic, our presentation, our message in this presentation is just how we can identify which patients are going to do poorly with an arthroscopic Latarjet, and then finally end off with what is my preferred approach. So this is Bankart. So he's actually the first one that popularized the Bankart lesion, even though it was first identified before him. And he's a British surgeon, and this is a paper that he published, which was entitled Recurrent or Habitual Dislocation of the Shoulder Joint. And it was published in 1923. And he refers to this lesion, which is now holds his name, Bankart, as the fibrocartilaginous glenoid ligament. And he's the one that said that this was the essential lesion that we had to fix. Now, in North America, the arthroscopic Bankart procedure was really brought across the ocean by Carter Rowe. And so he was a surgeon in Boston, and he published this paper in 1963. 145 shoulders with the Bankart procedure. So this is done open, a very low recurrence rate, and a 98% good to excellent rate. So this showed us that this is maybe the most important operation to do for patients that have anterior shoulder instability. But I don't think we've ever been able to reproduce these great results. It's considered the gold standard, or was considered the gold standard in North America. But something has changed with the Bankart. The Bankart in 1963 is different than the Bankart repair that we're doing now in 2021. And what has changed? So this is a paper published by my friend Brett Owens, and he just looked at the rate of open Bankart repair compared to arthroscopic. So this red arrow represents open Bankart repair as the years go by. The blue arrow represents the arthroscopic Bankart repair. So you can see we're not doing as many open Bankart repairs. We're almost all doing arthroscopic Bankart repairs. But we know our success rate is not 98%. So what is the difference? So we know from several research papers that the arthroscopic Bankart is not equivalent to the open. This is a paper published by the Korean group, Young Girl Rhee, American Journal of Sports Medicine, and they looked at contact athletes. The recurrence rate in the open was 12%. The recurrence rate in the arthroscopic was 25%. So 1 out of 4 patients failed the arthroscopic Latarjet. Still means 75% good outcomes, but 25% is double the rate of recurrence of open. This is a paper published by Alex Castagna, 21% recurrence rate with the arthroscopic. This is a paper published by E.G. Itoy. He looked at open versus arthroscopic Bankart. The open 2 times, arthroscopic 3 times higher rate of recurrence in contact and collision athletes. So we certainly see that in these original papers, the open is much superior than the arthroscopic at preventing recurrent instability. So I think of the arthroscopic Bankart as a hammer, and this is my toolbox. As a carpenter, it is probably one of the most important tools in my toolbox. But if all I had was the hammer, I probably wouldn't be a good carpenter. I still need other tools. And so I need to identify when I need these other tools to build a good structure. And so the hammer is one of the most important. So we all have to know how to do the arthroscopic Bankart or the open. But there's other tools that are important. The Latarjet is a very important tool that we should understand and have in our toolbox. The Bristow also. Remplissage, we're going to talk a little bit about that. Islet crest bone grafting, so a bone block procedure, distal tibial allograft, and the open Bankart procedure. These are all things that we should consider if we're managing patients with complex shoulder instability. We should have an understanding of some of these other problems and have them all in our toolbox also. So the message that I want to send is that we have to know and we have to be able to identify patients that are going to do poorly with the arthroscopic Bankart procedure and then escalate the operation. So we want to identify which ones are not going to do well or have a higher recurrence rate with the arthroscopic Bankart. And then once we identify those, what of those elevated operations are we going to do to help them? So when we identify, or how can we identify, this is an excellent paper published by my friend Pascal Boileau from Nice, France, and also Frederic Balg, who's from Canada. And what they did is they calculated this injury severity index score. I must admit, I don't calculate the score in every patient I see. I don't. But I think of what they said. They said that patients that are contact or collision have a higher rate of recurrence with arthroscopic Bankart, younger age, hyperlaxity, glenoid bone loss, and Hill-Sachs defects. So now when I see a patient, those are some of the questions I ask. What sort of sports they play? I look at their age. I do a Beighton score to determine their hyperlaxity. And then it comes to assessment of glenoid bone loss and a Hill-Sachs. So the first three, or the first two you can get from history, hyperlaxity, we get a physical examination, and then we need imaging. We need imaging to determine the last two. So how do we identify bone loss? There's many different ways we can identify bone loss on x-rays, but I think it's not perfect for me. I can't really calculate a good percentage from x-rays. We can do it intraoperatively. So this is an arthroscopic measurement where we measure from the bare area. So this B in the bottom left represents the bare area, and you can measure that. However, J.T. Tokish published this paper, which I found was very interesting, that he felt that only about 50% of patients actually have a bare area in their glenoid, and of them, only 40% is that bare area in the center. So the bare area measurement may not be perfect in determining the percentage. So for me, I think some of the best way is preoperatively with a 3D CT scan. So with a CT scan, you can do the circle method, as you can see here, where you make a circle along the inferior aspect of the glenoid and then measure the bone loss. The technique I prefer to use is this paper here published by Josh Giles in the American Journal of Sports Medicine, and I'll share that with you. I'm conflicted because I was an author on this paper. But what we did is, if you look at the glenoid, there is a direct proportional relationship between the height of the glenoid and the width of the glenoid. In men, this regression formula, the glenoid width, is the height of the glenoid times 2/3 plus 5 millimeters. And that'll give you the normal width. In women, it's height times 2/3 plus 3 millimeters, as you can see here on the bottom. So let's go through how that would work. So this is a patient that's had failed arthroscopic Bankart. You can see they have glenoid bone loss, but how much glenoid bone loss do they have? So if we plug in the formula and measure the height, let's just say the height measures 46 millimeters. If we put 46 millimeters into the formula, 46 times 2/3 plus 5, as an Indian, I'm very good at math, like everyone is. And so the answer is 28 millimeters. So that'll give us our normal, pardon me, that should give us, I messed this up here. It's 36 millimeters, I'm sorry. So 2/3 height is 36 millimeters. That's what the normal width of this glenoid should be. So the bone loss is the native width, which is 36 predicted, minus what the width is. And in this patient, the width is 28 millimeters. And so that gives us 8 millimeters of bone loss. So we're missing 8 millimeters in this patient. So how do we convert that into a percentage? It's just 8 divided by 36 times 100, and that gives us 22%. So for me, this is just an easy way for me to get an estimate of how much bone is missing and what that percentage is. And I prefer this over this, the circle method, but both methods are fine. Whatever one you choose, just be consistent, and then we'll be able to determine the bone loss. Now, the important thing when thinking about glenoid bone losses, and we're going to talk about this in the end, is what is the critical number? Some of the new literature is saying anywhere between 10 and 13%. I still am pretty aggressive, and I like to think 10 and 13% is very reasonable, but some people go up to 15% bone loss is when you should convert. It used to be that I think the older teaching was 20%. I certainly believe that we should be going down in determining what that critical bone loss is. Now, we've talked a little bit about the glenoid. Let's talk about the humerus. So with humeral bone loss, we know that it was described actually quite some time ago. In the 1800s was the first description of humeral bone loss that's related to anterior shoulder instability. But interestingly, back then, we didn't know what caused it. We knew we saw this in patients with instability, but we didn't know what was causing it. This is that original paper by Harold Hill and Maurice Sachs, Hill-Sachs, back in 1940, published in the Journal of Radiology. It's interesting, if you read the paper, they had 2 patients that came in with these lesions or defects in the back of the head, and they didn't know what was causing them. They thought, if you look what's outlined in red, they thought it might be due to infection, metastases, and post-traumatic osteoporosis. I'm not sure what that is. But they didn't know what was causing this. And so that's why they looked at 120 or 119 cases, and they were the first ones to identify that this divot or lesion or fracture in the back of the head was actually caused by the instability. And so that's why we call it the Hill-Sachs defect now. They were the first ones to say, well, this defect here was caused by an acute anterior shoulder dislocation, the so-called Hill-Sachs defect in 1940, published in the Journal of Radiology. Now, the important concept with Hill-Sachs defects is, as we all know, is engagement. So when was engagement first described? Well, the first description that I can see was in 1948 in JBJS, and this is by Palmer and Wyden. And this is a picture from that article in 1948, and you can see what's happening is as what they're showing in the bottom left side of pictures, as the person's externally rotating, the Hill-Sachs defect is coming anterior, and eventually it engages here on the right and dislocates. And if you look at their paper, they say the rim of the glenoid slips into the furrow of the humeral head and the joint is subluxated in the typical manner. Believe it or not, they felt that this defect was actually the essential lesion, not the Bankart, but this defect was the essential lesion. And this concept of engagement was reintroduced in the year 2000 by Steve Burkhardt and Joe DeBeer. And you can see here in their sort of animation that as we externally rotate, eventually the rim of that Hill-Sachs defect is going to come adjacent to the anterior rim of the glenoid, and then the head is going to slide over and dislocate. Now the question is how important or how big does this lesion have to be before we have to escalate the operation? And there's a lot of controversy in this area. If you look at Pascal Boileau's paper on the injury severity, he said just even seeing one. So if you see one on the x-rays, that's a significant one. Jill Walsh said about 20% of the anterior en face view. And then we now know that a concept that's popularized by E.G. Itoy and Yamamoto is the glenoid tract concept, where you measure that to determine when it's going to engage. Unfortunately, I don't personally believe that any one of these is perfect. They all have problems. So what are some important factors to think about when we see a Hill-Sachs defect? So we know that width, the greater it is, the more of the humeral head involves, the more likely it is to engage. The orientation is also important. So if I had a Hill-Sachs defect that was vertical, so the Hill-Sachs defect was above the head, and I rotated with my arm at the side, that would never engage. Because if the defect is all above the equator, the bottom part of the head is always going to articulate. However, if the defect is very vertical, then it's going to engage in adduction. So the orientation of the defect, this is stuff we study in the lab, is important, but it's very hard for me to measure that on a patient. You have to use a 3D CT scan to do that. Some people believe the depth of the lesion is important, and I personally believe it doesn't make a difference. So let's look at this picture up here. So let's compare a very deep one. So this one right here is going to be a very deep Hill-Sachs defect, and let's compare it to a very shallow one. So let's make this is the shallow one, so not too deep compared to deep. What happens is as we rotate forward, once this portion of the Hill-Sachs defect slides over the rim, it's going to dislocate, whether it's a very deep one or a short one. So I don't personally believe depth makes much of a difference. Range of motion does. If you look at this gentleman here, he's very muscular. And as he's so muscular, he has very poor external rotation. He can only externally rotate to maybe 10 degrees. So he could have a very big Hill-Sachs defect, but because his muscles prevent him from externally rotating, he'll never engage that. So his glenoid track will say that you should fix this, but his preoperative range of motion says he'll never engage that. versus this girl, look at her. She's so flexible and has so much horizontal extension and external rotation that she'll probably engage a very small defect. So pre-op or range of motion is also important, as is laxity. So if you look at this model, this is a computer model of a 20% Hill-Sachs defect. In a 20% Hill-Sachs defect, when we tried to manipulate it, we couldn't get it to dislocate. However, if we keep that model at 20%, but then add some laxity to the joint, so we let the joint translate a little bit, and we know that the shoulder joint does translate, now that 20% Hill-Sachs defect engages. So laxity, or how loose someone is, also has an influence, and that's not kind of incorporated into the glenoid tract concept. So that's something we have to think. The more hyperlax is, the smaller the defect, the easier it is to engage. Because I think we've all done this before, that we're in the arthroscope, we're in the surgery, and we just slide the head forward. We don't rotate it, and we slide it, and it still engages. So that's something to think about, is that engagement with a Hill-Sachs defect, I personally find very complex. And I don't think there's one formula that tells us which one's definitely going to engage and which one's not going to engage. And so the final thing is also glenoid bone loss. So if we're losing more glenoid bone, those Hill-Sachs defects are more likely to engage. So these are all the concepts that are in the background when looking at a Hill-Sachs defect. And so this is probably my way of thinking about complex instability in 2021. So in January of 2021, you can do a glenoid-based reconstruction, you can do a humeral-based reconstruction, or you can do both. In general, my approach is I tend to be more glenoid-based. Rarely I'll do an isolated humeral one, and we're going to talk about that. So what do we do? So this is the way I think about complex shoulder instability. So we want to identify, does my pointer come up? If it does, just give me a thumbs up. Is it coming up? Good. So you want to identify the glenoid and humeral bone loss. And as surgeons, we have to decide, you personally have to decide what is the important number for you. For me, this number where the glenoid bone loss is critical is 10 to 13%. That's when I start to think I want to do something escalate. Some people, this number will be 15%. Some people will be 20%. For me, it's pretty low. And then I look at the Hill-Sachs defect. So with minimal glenoid bone loss, minimal Hill-Sachs defect, those patients, I think, are still going to do well with an arthroscopic Bankart procedure. Now, what about when the glenoid bone loss is still small, but the Hill-Sachs defect is bigger? I believe I still have to do a glenoid-based operation. So whether it's the Bankart, but if I do the Bankart, I personally believe I have to add something for the Hill-Sachs. So if a larger Hill-Sachs defect, minimal glenoid bone loss, Bankart plus rim massage, or you could just do the Latarjet. There's other options available to you too. There's the option of putting allograft into the Hill-Sachs. There's the option of osteochondrografting, partial resurfacing, humeralplasty, trying to elevate it, and also the rotational osteotomy. These are, I would call, more fringe operations. I would say this is probably the more traditional approach, and this is more fringe. So I tend to steer away from these and do more traditional operations for this patient. Now, what about the very large Hill-Sachs defect? You see these in patients that tend to have seizures. And those patients, those are the ones where I will consider doing a more aggressive operation, like an allograft reconstruction of the humeral head, a partial resurfacing to fill in the defect, or in an older patient that maybe 75, you can actually consider just doing a hemiarthroplasty if the Hill-Sachs defect is too big and the bone quality is very poor. So I escalate the operation based on age in that patient population. And finally, what about the most frequent one? So you have a 10% glenoid bone loss, whether or not you have a Hill-Sachs defect. For me, once I get substantial critical bone loss past 10 to 13%, my preferred operation is a Latarjet, and you can do it open or arthroscopic. I prefer to do it arthroscopic, but there's no difference. But you can also do bone block procedures or combined procedures. So a bone block procedure would be like removing the distal clavicle or an iliac crest or a distal tibia. So my preference in this group right here, which is probably the most frequent group that I look after, is the lateral. But saying that, if you've had failed prior Bankart repair, you automatically move into this group. Doesn't matter for me what's happened in the past. If you failed an arthroscopic Bankart procedure, I honestly move right away to one of the more escalated operations. So in summary, for the first presentation here, we have to identify the patients that are not going to do well with the gold standard operation. And those patients are younger patients. They have hyperlaxity, they play collision and contact sports, or they have bone loss, and they have bone loss on the glenoid, and the critical number for me is 10 to 13%, or they have a substantial Hill-Sachs defect. Those patients, the literature has shown we need to escalate the operation. And whether you escalate it to a Bankart plus a remplissage or a lateral or a bone block, that's based on surgeon preference, and that's based on your own personal experience. And so that's what I was going to share with you with the first presentation. And I'm happy to take any questions, or we can move on to the second one, whatever the moderator wishes.
Yeah, I think we can take some questions, because so that it gives you a break also.
Thank you for the talk, Professor. Professor, do you have any questions to ask?
Yeah, I just have a couple of questions. One is, of course, the audience here is mainly the practicing orthopedic surgeons, and there are young surgeons who are into orthopedics just now. I think they need to get a message about this anterior instability or whatever, instability of the shoulder. See, when we get a patient for the first time, young adult, maybe sports person or anybody, what do you recommend, Dr. George? Is it a CT scan or a MRI or both? What is the investigation of choice? Or you don't want to ask any of these? Just reduce it in the OR or whatever means, and then send them. What is your advice? What is your thoughts on that?
So in a younger person that's an active person, maybe they play rugby or football or some sort of collision sports, and they have a first-time dislocation, we know that if they're under the age of 20 or 22 and they play competitive sport and they have a dislocation, the chance of them having another one is higher. So my personal preference is I get a 3D CT scan, and I like to look at if there's a glenoid fracture, if they're missing glenoid bone. The reason I like to get the CT scan is it gives me a good visualization of the bone. Many people like to get an MRI. I get an MRI if they're older patients, so older meaning 35, 40, 45, because I want to rule out a rotator cuff tear. But I don't get an MRI in the young patients because I know that they have a soft tissue injury. I know they're going to have either a Bankart lesion or they're going to have a Hagel lesion. And so based on arthroscopic, when I get to the surgery, I'm still going to fix the soft tissue lesion. I know it's there. But what changes the operation for me is the identification of the bone loss. So that's why I get the CT. If I see that there's more bone loss, then I'm not going to do a Bankart. Then I'm going to escalate the operation. So I think for me personally, because I feel comfortable managing instability arthroscopically, the CT scan is important. If, however, you feel, or some people feel uncomfortable managing the Hagel lesion arthroscopically, then it's reasonable to get both. If you think that this patient's going to benefit from an operation, it's reasonable to get both. Personally, I would only get the CT scan. In Canada, a CT scan is much cheaper than the MRI too, so that's another reason to do it. But for me, it's truthfully, it's about the bone loss.
Dr. George, if you take the CT scan, what about the slap tears in the regular? In India, we play a lot of cricket, we play a lot of badminton, tennis, or a swimmer. So don't you think we miss a major explanation part about the rehabilitation and the duration of his return to sport?
So if a person has an anterior shoulder dislocation, first time dislocation, and let's just imagine they have a slap tear along with it, but I got a CT scan. If the patient doesn't want surgery, you can still treat a slap non-operatively. You don't have to operate on it. If a patient has a slap and their pain goes away, I'm not going to treat that slap. I'm going to let them go back to sports. Now let's imagine we see the same patient. It's their first time dislocating, and they say, listen, I don't want non-operative. I want you to fix me. I want you to operate on me. I get the CT scan. If there's no bone loss or bone loss, whatever, but when I'm going to manage every person with instability is going to get a scope. So I'll see the slap then and I'll fix it then. So in my thinking, it doesn't change what I do. However, it's come because I feel comfortable managing it when I see it. But if someone wants to know everything before they get to the surgery, know that for sure there's a slap or not, then you may have to get a CT arthrogram, an MR arthrogram, because we know a slap tear sometimes on a regular MRI is very difficult to manage. So then you'd be getting an MRA on every person that you're going to take. It's not unreasonable. It's just not something I feel I need to do, because if I see the slap, I'm going to fix it. If I see a slap in a person that's 30, I'm going to do a biceps tenodesis, and I'll still do the instability.
Yeah, there is a question, Dr. George, from Kerim Bilsel. He's asking question from Istanbul. So it's nice that people are watching in Istanbul.
I've been to Istanbul.
So
been to Saint
the
Sophia.
message says that, thank you, George. My question is how you manage the bony Bankart situations, repair or lateral J?
Oh, yes. So with an acute fresh bony Bankart, if it's, so I have a whole 20-minute talk on that, but we won't do that today. If it's small, I'll fix it with sutures. So I'll put suture anchors, and I put suture anchors around it. If it's slightly bigger, and there's no exact percentage, it's just when you're looking at it on the CT scan, then you can do a double row suture repair. So you put suture anchors along the medial vault and then over it, and then onto the front. And if it's a glenoid fracture, so it's like a 20% glenoid fracture, those patients I'll fix with screws, cannulated screws arthroscopically. And I actually use the ladder J system because it's got nice screws, and I use that to fix the glenoid fracture. So in general, if you have an acute Bankart fracture in a young person, so acute bony Bankart in a person that's 20, 25, those ones I actually lean towards operating on sooner. I'll tell them that, you have fractured the rim of the glenoid, you're young, you're 20, you're 25, the chance of recurrent instability is higher, and it's an easier operation for me to fix the Bankart to put your bone back together than it is to do a ladder J later on. So the very, very, very rare indication to do an acute ladder J for me is if it's a fragmented rim. And the times I've seen that is when they've already had an arthroscopic Bankart, they dislocate again, and they fracture through where the sutures were, the suture anchors, and then it's more poor bone. And those patients I'll do an acute ladder J, but those are pretty rare.
So what about the second time dislocators after the Bankart's repair, considering the other factors are normal? For example, the bony factors are not there, but still the person is dislocated. Would you attempt the second time Bankarts, or your choice is towards, escalating the procedure?
Yeah, that's a very good question. I'm biased. I'm very biased, and if they've failed an arthroscopic Bankart, I must admit I just go to the ladder J, because patients come with me with failed Bankarts, and I just don't like doing the other Bankart and having that 20% chance they fail. I'm going to go, for me, it's, as you will know, my third presentation, I call the ladder J the Superman of instability operations. So I'll go right to Superman.
Okay.
Dr. George, the literature, whatever has been shown in the first topic, discusses only about Bankart and failures of only Bankart without addressing the Hill-Sachs lesion. So the failures are totally biased in giving a 20% failure rate or a 25% failure rate, because the underlying issue was not solved. And either it is open procedure or it is an arthroscopic procedure, the addressing surgeon has not addressed, or the review of literature. Whenever I think about it, so we have not addressed the real issue in toto. The Hill-Sachs has not been addressed, and we try to get bias towards open surgery and arthroscopic surgery. when the real issue has not been addressed. So do you really think we should go by the literature trying to say that open procedure or a closed procedure should be converted into an Latarjet directly? So as you know, the French always try to say go for a Latarjet. Yes, it is good, well and good for an active population where the rugby is one-to-one contact. In our Indian circumstances, where we are not very contact sport people, we're not very aggressively sporting contact sports, even though there are sporting people, not very contact sport.
Right. So I
So
think
do you have something to change?
yes, for sure. So that's, if you look at this flow chart here, that would be here, meaning that, so it's based on surgeon preference, but you have to, I agree with you 100%, you have to identify the other problem. If you miss it, then you're just going to do the Bankart, and we know that they're going to fail, or they have a higher failure rate. So once you identify it, if it is the Bankart plus the remplissage, you can either do, sorry, if it's a Bankart plus the Hill Sachs, you can do a Bankart and remplissage, which is a very effective operation, or you can do the Latarjet. For me, if the person is a collision athlete, they're low demand, I would consider doing the Bankart and the remplissage. But in most cases for me, I go to the Latarjet, but there's no difference as long as you identify it. And so that's why I've put both of those as options here. It's what you're comfortable with.
George, one last question before, as there are no questions, probably we'll move on to the next video. But before that, one last question is, because you said the nice variable factors like laxity in some of the individuals, do you think that makes your decision different from selecting the procedure?
Yes, yep, definitely. So I really, with what Pascal said about the injury severity score and how right here, hyperlaxity, the middle one, for me it does. And so as an Indian in Canada, I also treat a lot of Indians because they look for me, they come to me. And as you know, we are much more flexible. We have good elasticity. So hyperlaxity, I'll do, bite and score, see if they can touch their thumb down, external rotation. And if they're sitting at 10% bone loss or 8% bone loss and they have hyperlaxity, I will tell them that the risk of, I let them choose. I'll say the Bankart procedure is a well-done gold standard procedure. It results in 80% success rate, but a 20% revision rate or 20% recurrence rate. Advantages, very low risks. And then I say on the other side, we have a bigger operation. It's called the arthroscopic Latarjet, has a recurrence rate of 2 or 3%, but a higher complication rate, a risk of higher rate of nerve injury and stiffness. And then I let them decide, do they want to go with the bone block or the Bankart? And then when they make that decision, especially on an equal, then they have to live with that decision. And I feel comfortable. If I feel comfortable doing both, I let them make the decision.
Thank you. I think we'll move to the video demonstration of your next talk.
Yes. So I am a fan of the Latarjet. And one of the, I guess, the disadvantages of the arthroscopic Latarjet for me is it can be a technically challenging surgery. So I have to keep doing it, meaning so that if there's a patient that's, you could do an arthroscopic Bankart and a remplissage or an arthroscopic Latarjet, I'll probably lean them more towards the Latarjet because I need to keep my skills up too. And so, I mean, I'm not doing 3 or 4 of these a day. I do one every 2 or 3 weeks. And because I have to keep my skills up, I consider this as I'm biased once again. So I'm sharing with you all my biases. Just don't let them come back to me, okay? So arthroscopic Latarjet surgical technique. So really, we'll just go through briefly the background of the Latarjet, and then I'm going to go into the arthroscopic technique. So this is Michel Latarjet, 1954. This is not his true description. This is basically the contemporary modifications that have occurred over the years on the Latarjet. So you can see that we're going to go ahead and osteotomize the coracoid tip at the elbow, and then we transfer it down, and the classic Latarjet, the inferior aspect of the coracoid, is going to be placed flush to the glenoid and contemporary modern technique is that we use either 2 screws, or you could also use cortical buttons. My preference right now is to use screws. And the important aspect of this Latarjet is right here at the tip where we have the conjoint tendon. And so this is one of the purported advantages of the Latarjet over a bone block procedure, is that you can see the conjoint tendon is going to take a circuitous route through the subscapularis. And people believe that this adds some enhanced anterior stabilizing effect with the so-called sling effect. And I'll show that to you in the video. So now with the Latarjet procedure, we know it can be done open or it can be done arthroscopic. Now, some people will say that the arthroscopic has advantages. You can identify associated pathology such as a slap tear. So if you have a slap tear, you can identify it. You can identify a posterior labral tear. You can also identify the nerves, in my opinion, easier arthroscopically than open. Some people say the graft positioning is better arthroscopically, and some people say that an arthroscopic procedure enhances your skills. I personally don't agree with this, meaning that associated pathology, you can still put a camera in, do a diagnostic scope, and then convert to an open Latarjet. That's okay. So that's not an advantage. If you're a good nerve surgeon, you're a good nerve surgeon open arthroscopic. Graft positioning, I would say, me personally, is easier open. So with the scope, you see things 2-dimensionally. And every time you move the scope, it looks like a different view of the graft. But what you have when you do it open is you have your finger. And believe it or not, our finger has so many sensory nerve endings, and all we have to do is just touch the anterior glenoid and we'll say, okay, it's too proud, it's not proud enough. So my finger is better at graft positioning than my 2-dimensional eyes are. The only thing I do believe is skills. I think if you do it arthroscopically, you can work on arthroscopic skills, but maybe that's not the right reason. The disadvantages are true. It does take me longer to do an arthroscopic Latarjet than an open. There's a higher cost. An open Latarjet, you don't have all the disposable instruments, all the arthroscopic stuff, and the learning curve. So there are several disadvantages to the arthroscopic Latarjet. But saying all this, I still prefer to do it. And it's funny, I've done so many arthroscopic, I think I'm probably, maybe I'm nervous doing it open now. I don't know. So let's talk a little bit about the technique. So when you consider doing the arthroscopic Latarjet, you have to have a good team. You have to have good assistants. I joke, you say you have to be prepared and rested. It shouldn't be the last case of the day that you just put on. It's something that when you're first starting to do it, you want to prepare for it, you want to think about it, you want to have maybe some notes, and you want to do it early on when you're fresh. And the best thing about the arthroscopic Latarjet is you have to have a backup plan. And the best thing is the backup plan is the open Latarjet. So you, at any time, you can always transition to the open as long as the tissues don't swell up too much. So these are the 5 steps that the way I see for the arthroscopic Latarjet. And so we're going to start off with step 1. The camera is in the standard posterior portal, and this is a right shoulder. And so basically what I'm showing here is where I'm going to place the graft. I'm going to place the graft at 5 o'clock, and we're going to look up and go at 2 o'clock. So I actually mark on the glenoid because, believe it or not, as the operation goes on, you can lose that. So once I've marked the location of the graft, you can go ahead and prepare the glenoid vault, and then you need to open up the rotator interval. So now this is the rotator interval here, and I'm looking for the conjoint tendon. There's the conjoint tendon right here. And now this is the CA ligament right there. So I'm going to detach the CA ligament from the coracoid. That's the coracoid, and just take it off the lateral side. And then what we're going to go ahead and do is prepare to make an anterolateral portal. So this spinal needle is going to be my anterolateral portal. Okay. So what we've done is, step 1 is we have the camera on the back. We marked the position of where the graft is going to be. We debrided a bit of the glenoid vault. We opened up the rotator interval, like what we do for a subscap repair, identified the coracoid, the conjoint tendon, and detached the CA ligament. And now we're going to make this anterolateral portal. So this is just going to be right in front of the biceps tendon right here. And so now we're going to transition and put the camera in through that, and we'll get a good view down at the glenoid. So here's the view. So I've put the camera in through the anterolateral portal. There's our 2 o'clock mark, And down here is going to be a 5 o'clock mark. Here's the posterior labrum. Here's the anterior glenoid bone loss. So we'll start playing that. So you can see there's the subscapularis, the rolled upper edge. And so now what I'm going to do is I'm going to bring in a shaver or a burr, and this is just a little bit of a malunited bony Bankart, and prepare the anterior glenoid. So just shave up and down so we get nice, healthy bleeding bone. There's the 5 o'clock mark. But let's look at the anatomy. So there's the base of the coracoid right there. So we're just cleaning that off. The axillary nerve and musculocutaneous nerve are going to be in there. So on the right is the conjoint tendon, and on the left is the subscap. So here's the subscap right there. And so now I'm on the superficial side of the subscap, and then I don't use, obviously, I'm just using this as a dissector, but there you can see the axillary nerve. And now the musculocutaneous nerve is on the deep medial surface of the conjoint tendon, and it's going to be right there. There it is right there. So just on the deep side. So let's look at the anatomy. There's the conjoint tendon going all the way down to the pec major, and we'll follow it up. There's the tip of the coracoid, the stalk, and there's the base of the coracoid on the glenoid, subscapularis, axillary nerve, musculocutaneous nerve. So you can see the view that we have from the anterolateral portal. So we can see everything that we need to see outside and inside. And now what I'm going to do is, this is a switching stick coming in from posterior. And I'm just going to push this through about the mid-substance of the subscapularis. I'm just going to push it through. I want the switching stick to be parallel to the glenoid, so that's going to orient my screws. And then I'm going to go, look, there's the switching stick right there. And my axillary nerve, if you can see in the background, is medial to the switching stick. And now I'm just going to pass this lateral to the conjoint tendon. And then we're just going to pass it through the pec major. And so I make a separate incision in the up here, and then we add in this sort of channeler device. So this is called the medial portal. So we've done now is we've prepared the glenoid, looked at it, identified the musculocutaneous and axillary nerve, and then we've also dissected out the conjoint tendon. So we've got a good panoramic view of the shoulder. And now we're going to go ahead and prepare the coracoid. So there's the coracoid tip. In here is going to be the superficial visualization of the musculocutaneous nerve. And there's the top of the coracoid. There's the anatomy again. There's my switching stick coming through the subscapularis right here. There's the axillary nerve, very close. So now we're going to go ahead and make the subscapular split. There's the sisters, and there's the upper border of the subscap. So I'm going to pick the 50% margin here. So right about there. And so that's the biceps is going to be there laterally. And so now what I'm doing is just burning through the subscapularis, and there's the humeral head. And so I'll back the switching stick out and use it to flip up the upper 50% of the subscap. And there you can see deep down there is our glenoid. So let's look at the anatomy again. There it is. There's the coracoid. So once I've done the split, now I'm going to go ahead and prepare the coracoid. So this is the coracoid right here, and we're going to look at the pec minor. And this is the pec minor tendon that I'm taking off right there. So there's the pec minor muscle, and here's the pec minor tendon. So I've detached the pec minor, so we have control of the coracoid on both sides. But let's look at the musculocutaneous nerve. So the musculocutaneous nerve is going to be about 1 centimeter to 2 centimeters from the coracoid tip, and it's right there. So there's the musculocutaneous nerve. It's very close to the coracoid tip, right there. So now once we've exposed the coracoid, we're going to prepare it. So I bring in, this is a technique guide set from one of the companies, but there's many out there. This is a cantilevered screw system. So basically I place 2 guide pins into the coracoid. I drill, I tap, and then I insert these 2 washers that screw in, and then we've prepared our coracoid. And then once we prepare our coracoid, the next step is to osteotomize it. So this is a guide that comes in through that medial portal. And now we're ready to osteotomize it. So I'm just going to go ahead with a curved osteotome, come in through a portal up here, and then crack it. And there it goes loose. And then we pick it up and screw it onto the guide because we tapped the coracoid. There we go. And now the next step is we have to prepare the coracoid. So you can see that the coracoid's got some extra bone on here. So I'm bringing in a burr, and I'm just going to burr it down. And then I'm going to prepare the deep surface and make it flush like that. So we did the split of the subscapularis. We osteotomized and prepared the coracoid. And now for the final step is where we transfer the coracoid in. So there's my switching stick lifting up the upper half of the subscapularis. And here comes the coracoid. Just like you would do it open, you turn it and move it through the split. And then I want to rest it between that 2 and 5 o'clock position. So let's take a look. There's our glenoid. We're going to move it. And I'm going to place it flush to the subarticular bones, just like that. So I like it to be just a little bit medialized so that the cartilage on the glenoid is proud, and this is the bone lines up with the bone. And then you put 2 guide pins in and just trade them for 2 screws. And there's our sling effect. There's our sisters to the left. But let's look at the anatomy. There is the axillary nerve. So let's do it again. So this is, there it is right there. So that's 2 o'clock, 5 o'clock. There's the coracoid graft. Let's back out. That's the subscapularis. There's the sling effect. Now let's look at the nerves. There is the muscocutaneous nerve touching, essentially touching the coracoid transfer. Now the axillary nerve is going to be right there. You can barely see it, but it's very, very close. And whether you do this operation open or arthroscopic, these nerves are in the same location. So they're very close to the graft. So we have to be very careful. And I believe it's very important to be very careful when you're doing this operation open, because those nerves are just essentially millimeters away along the medial side of the graft. So another way that may be safer to do the subscapular split is this, where I put the camera in through medial. So now what we're doing is the camera is coming in through this medial portal, and you have a very good view of the subscapularis, and I call this a delta pectoral approach. So there's the sisters right there. And here's the whole subscap, and you're looking at it just as if you were doing open shoulder surgery. The axillary nerve is right there. And then you can see the top part of the subscap, the bottom part, and you can predict or look at where you want to make your split. It's a much more direct view when having the camera come in from medial. So this is just another option because some people find it difficult to do the split with the camera coming in lateral. So there we go. We'll go ahead and do our split. Just another different way of doing it. So in summary, when we think about the arthroscopic lateral J, it's a 5-step process. If you look at each one of those individual steps, they're not complicated, but many times when you add them on, it can get a bit daunting. So I think if someone's considering doing this, consider visiting a surgeon that does the arthroscopic lateral J and seeing what they do. Build up your learning curve, do small portions of the operation. And you can also do the operation in cadavers. And I did my first one in a cadaver before I did mine on a live patient. So I think I practiced learning. I visited someone. I did it on a cadaver before I did it on my first patient. And so that's a technique video on the arthroscopic lateral J. I know it's not for everyone, but this video also can help you when you do it open. And I think the most important thing for me is to identify, or know, not necessarily identify, but know where those nerves are and to be careful that they're just medial to where you're placing your graft. Thank you.
Yeah, that's wonderful demonstration, especially the orientation what you gave when you're looking from the anterolateral and anteriorly, as if the anatomy is the same, how it is seen when we do open surgery. That was wonderful. There is a question from our senior faculty from Bangalore. Dr. Uday Kumar is asking, have you had to do an open lateral J when you were doing the arthroscopic lateral J?
Yeah,
was there any occasion like that? How did what was the reason and how did you manage?
Yes, so that's I'll be very honest, I've been very lucky in that when I did My first 10 or 15 patients, when I booked them for my first one, I said, there's a 50% chance I'm going to have to open this. And I have not yet, and I've done about about 160 to 175 of these now, not quite 200, but about 100, I think I have 175, close to there. I've not had to convert to open. But in my first 25 patients, in the consent form, I would say arthroscopic possible open Latarjet, and I would tell them that there's a chance I may have to open this if the swelling gets too bad, or if I feel uncomfortable, or if I've done something wrong. When we looked at our first 90, so me and 4 other surgeons, we looked at our learning curve and our early complications, and out of 98 patients, 1 surgeon had 1 where they had to convert to open. I agree 100% with Dr. Kumar that you have to be prepared for that. If you're going to do this operation, you have to be prepared to tell your patient that you're going to convert to open, and you have to be prepared to do it and have all the instrument available to do it.
Yeah, that's nice. And I have one question. You showed one instrument which is holding the graft when you're going inside. What is that, and who makes it? I've never seen such kind of an instrument.
Yeah, so that's made by DePuy. Dr. LaFosse designed that system. And so it's essentially a disposable guide that has 2 screws that are non-disposable that grasp the graft. So it makes it a lot easier.
Exactly. And George, anytime have you come across a fracture of the glenoid when you're doing especially the screw placement, especially if this graft is small and the hole is little eccentric? And is there any chance of fracturing the glenoid?
The glenoid or the coracoid?
The coracoid,
Yeah,
sorry.
Yeah. So in our first series, I've fractured it once. And what I did is, it was my own fault. And so I'm going to draw a picture. So what I did is, I did not do a good job of preparing the undersurface of the coracoid. I didn't make it flat. And so because I left it curved, when I tightened the screws, it cracked there because I didn't do a good job I left it like this and it cracked. So I'm very critical of making sure the coracoid is perfectly flat and matches the glenoid now. But yes, that can definitely happen. In our first, I think 98 patients in our paper that we published, we had 5 coracoid fractures.
How did you handle that?
So the one coracoid fracture that I personally had, it cracked, but it stayed stable because it didn't crack through the holes. It cracked the 2 pieces separated, but I still had fixation in the top and the bottom, so I left it. But and it healed. The dangerous one is when it cracks up here or you lose fixation. And then what we've done, I know what one of my partners did, he put a suture anchor here to hold the conjoint tendon to provide extra fixation of the conjoint tendon.
Okay.
So
do you modulate your screw system when you're taking the coracoid for a bigger coracoid or a smaller coracoid, one lesser dimension, one bigger dimension?
I don't. But that's interesting because I know when I do operate on smaller patients, the screws are pretty snug, and I think in some places in India, people can be quite small stature. Yep. So that's a very valid concern. I have not had to do that yet. Maybe I should. Right. So the system that I have has 1 set of screws, and I just use those. But so far, I've been lucky, and I've had 1 fracture. But I have to be careful for that, for sure.
As long as the one cortex, the undersurface of coracoid is the cortex is taken away, the cancellous bone allows you to get compression, so the chances of fracture are quite less. So we don't decorticate the undersurface of the coracoid, then we have a rigid bone where the chances of fracture, when we are tightening out of greed to compress it too stronger, we may fracture.
Yep.
And Are there any challenges when you treat a failed Bankart for a converting to a coracoid because of the type of anchors or the number of anchors or the material of anchors?
That's true.
Would you like to
Absolutely.
enlighten us?
Yep. So I think with the peak anchors, the bioabsorbable anchors, they tend not to cause too many problems. You just have to remove the suture material. And I find that most of the suture material is fiber wire, which can clog up your shavers. So it takes a little time to take this out. The issue we had is with metal anchors and guide pins. And so the more metal anchors there are, the higher the chance of impingement. And so in one of our cases that we published on, a guide pin deflected off the metal anchor, and we couldn't insert the screw, or we had much more challenges inserting the screw. And so we had to change the orientation. But yeah, so when I see metal anchors, those make me a little bit more nervous. But you know, I have to say it makes me a little bit more nervous, but usually I'll just push through them.
Okay.
Yeah.
So normally when we try to push through them, the anchor rotates and it makes a bigger hole there.
You can do that, and also it creates metal debris. You get metal shards. And so because I pin the graft, so this is looking at the graft right here on FOSS, and I pin it here. I can take one pin out, and then I just kind of do a little bit of this or a little bit of this, and then put the pin back in, or take the bottom pin out and move it a little bit this way or this way. And if I move it towards the glenoid face, then I just come in with a little burr and just shave it down a bit.
Okay.
But this is how I typically like the graft position. So you see the bone right here is right against the bone of the glenoid, and the cartilage of the glenoid is more lateral. But yes, metallic anchors can be a little bit of an issue.
We stop using the power instruments to get the pilot hole. So we try to mallet it gently where the rotatory effect is not there on the implants inside.
That's a good idea.
So we try to go very, very gently inside, so that even when you are reaming the the pilot hole with a slotted drill, so we just try to do with the hand rather than rotate it with the power instrument. So we rotate it gently so that it goes very gently and doesn't allow the inner anchor to wobble inside there.
That's an excellent idea. I mean, we don't tend to see many metal anchors here. I can't remember the last time I saw them, but I think that's an excellent technique. So basically, you're not letting it rotate to contact, you're letting it push away.
Push out.
I'll do that for sure next time.
Thank you.
I think it's a great idea.
Do you think the sling effect is going to last long?
I believe in the sling effect. We studied it in our biomechanics lab, and every which way we studied it, we found that it was effective. It did enhance the stability. So I do believe in the sling effect, and so that's why I choose to do the Latarjet over other bone block procedures. But there are disadvantages with the Latarjet, and I'll show you them in the next slide. Or the next presentation, the problems can definitely happen.
Our senior, Dr. Rudra Prasad sir, does a lot of tendon transfers. Every tendon transfer where we shorten. If we shorten the tendon, the sling should not be effective technically.
Oh, yeah.
Because we have shortened the length of the tendon. Sir, Rudra sir. So whenever we shorten the length of the tendon, conjoint tendon, so technically the conjoint tendon sling should not be effective.
But the thing is that
exactly, I do agree with you.
In this position, you may not be, because you've shortened it. But now think of what's happening. You're moving your arm up, lengthening, and then externally rotating. So in the position up over here, it may actually, I think it is taut.
That's the first point. The second point, and all the tendon transfers over the period of time, they stretch over. And they're not effective after a couple of, maybe a couple of years. Most of the tendon transfers lose the strength after a couple of years. So we still should.
Do you find that may be different if we do the tendon transfer and maintain the bony insertion? Because I find that when I do a fair number of tendon transfers. I do lower trapezius, latissimus, and if I take bone and keep that bone security, I find that there may be less of a chance of that. Possibly. But we do know the operation works.
Yes.
You had it's a fantastic procedure, no doubt about it.
It has worked. And Dr. George, what's your opinion on the movement, achieving range of movement between the bankards and latter J? Because some of the people are a little apprehensive of losing some of the movements, and some people believe that it becomes a little more stiffer. But I believe latter J should not, cause any kind of a restriction. What's your thoughts on that?
So I want to say that the range of motion after is the same, but for me, my patients I do my latter J on take a lot longer to get their motion back, especially external rotation. With the Bankarts, they get their external rotation back fairly quick. With the latter J, I feel like whenever I see them, I'm telling them, you have to work on your external rotation. You have to do more external rotation. And I find that I believe that my latter Js are probably a little bit stiffer in external rotation than my Bankarts. I personally believe they're a little bit, but I'm willing to accept that extra risk of stiffness because their shoulders stay stable and the chance of recurrence is less.
What about the chances of arthritis in future following latter J? Because there is no articular cartilage and there is a movement against a different, biomechanical surface.
That's right. So if you look at this picture right here, that's why I placed the graft medial and adjacent to the bone of the glenoid, so the cartilage above. So this graft should not get loaded. I don't want it to be loaded. I rely 100% on the sling effect for this. Now, in patients that have a substantial amount of bone loss where I have to place a bone graft to recreate the glenoid, yes, then there's definitely the risk of arthritis in those patients. I think the majority of the risk of arthritis with the latter J was poor technique where screws were placed into the joint and you had post-traumatic arthritis. That happened a lot in North America earlier on with the Bristow procedure. It's published by Charlie Rockwood. So that's why I attempt to place my graft slightly recessed to avoid contact with the humeral head. And I also like to place my screws as parallel as possible also to minimize any impingement with the humeral head. Great. So should we move on? I think we're already at 10 after 7. Wow, that time went fast.
So I think we will move to the next talk of yours. So
yes.
Next is on the, there was a question actually from the same doctor from Istanbul. So I've said that next talk is on that. So what to do after failing latter J?
Yes. So over the next 15 minutes, we'll talk about briefly the outcomes of the latter J, the complications, and how do we manage them. So as I said, I think of the latter J like the Superman of shoulder stabilization operations. It has a very low recurrence rate, as you can see here, less than 2.5%, and a very high patient satisfaction rate. But just like Superman, if Superman goes bad, that's worrisome. When the latter J goes bad, it's also worrisome. And so there's several papers published on the complications. This is JP Warner's paper, 25%. This is Miniachi's paper, 30%. This is our personal paper. We had a 10% true complication rate. And this is Mullet's paper from Ireland, had a less than about 13% complication rate. So complications are higher with the latter J than with the arthroscopic Bankart. I really believe that. So we have to tell our patients that because we're escalating the operation, the risks potentially get a little bit higher also. So what are some of the complications? Hardware problems, resorption, graft fracture, non-union, malunion, recurrence, arthritis, and neurologic problems. So let's talk a little bit about hardware. Prominent screws and washers with a latter J, when you have prominent fixation. This is certainly a complication that I've seen. They cause mechanical symptoms. This is a patient that was referred after an open latter J, and you can see that the hardware is prominent. Here is the axillary view. And if you choose to take out this instrumentation of this hardware arthroscopically, the thing that you have to remember is the portals are going to be different. This yellow represents their standard anterior portal. If you want to take out this hardware arthroscopically, you have to make the portal much more medial than you're used to get in line with the hardware. So let's play the video. So here we have a right shoulder, there's our biceps, and there's our prominent hardware from this patient, a large fragment screw. And so there's portions of the graft which have healed. So what we're going to do is we're going to just go ahead and expose the hardware. And so we're going to do this very carefully because we know that the axillary nerve is just on the other side. Now I've switched into the anterolateral viewing portal and I can see the hardware. There's the subscapularis. And I'm going to insert just a spinal needle through the soft tissues, like so, poke through the subscapularis to get my trajectory for my screw, because my trajectory is going to be much more medial than you're used to. And then once I've got the trajectory, I'm going to put in the screwdriver, just dilate the subscap, put in the screwdriver. And now these screws are non-cannulated because this was done open. So you don't want the screw head to get caught in the soft tissues because you'll never get it out. So try to keep the screw intra-articular, back it out as much as you can, and then try to keep the screw intra-articular, which is easier to take out than if you back it out and it gets caught in the soft tissues, because once the screwdriver comes off, you can't find the head anymore if it's stuck in the soft tissues. So this is just taking a big pituitary, taking my time, slowly taking the screw out, and there we go. And then we'll take that out. So that's hardware removal. Now, what about graft resorption? So the rate quite high. So almost, some people say up to 90% graft resorption. It's usually asymptomatic. And I say usually because I'm going to show you a case. So this is a patient of mine. I did an arthroscopic Latarjet on, was doing very well. And then about 1 year after surgery, started to experience some pain, especially with forced internal rotation. He started to experience pain along the anterior aspect of his shoulder. I did a CT scan, the graft had healed. I did an MRI as much as I could. The subscapularis looked good, but he was having a lot of pain. So I said, I'll scope him. And so this is what I found at the scope. The superior portion of the graft had resorbed, and now the hardware is prominent and was rubbing against his subscapularis, and you can see created an articular-sided partial thickness longitudinal subscapularis tear. So whenever he was activating his subscapularis, the hardware was eroding into his subscapularis. And so in this patient, what I did is I just removed his hardware and his symptoms improved. So a relatively underreported complication of a Latarjet procedure is just prominent hardware causing a rotator cuff tear. So that's also a potential problem. So hardware removal. Now, what about non-union? Reported in up to 5%. Once again, interestingly, it's usually asymptomatic. It's rarely painful. And the other interesting thing is these patients are usually stable. So you may identify a non-union, but they don't have recurrent instability. So this is a patient that had a non-union which had mechanical pain. So you can see the non-unions right here. And so all I did for them, and they did not have problems with instability. So they said they had pain. And I asked them, does your shoulder dislocate? And they said, no, it hasn't dislocated since this operation. So in them, what I would do is I start off by just doing the hardware removal. And so you can see here, we're just going to expose, we're viewing from anterolateral, and there's a non-union. But once again, this patient is not unstable, they're just having pain. And so what I did is I just removed the hardware. You can see the hardware coming out in the picture on the right. But remember, the portal has to be much more medial for the screwdriver than you're used to. And their symptoms got better. So they were having a painful non-union that once I got the hardware out, their pain settled down and they did not become recurrently unstable. So I got lucky there. Now, what about recurrence? So recurrence of a well-done Latarjet. So if you've done a good job on the Latarjet and they still are dislocating, you have to think of why they're dislocating. If it's because of a bone problem, means that Latarjet is resorbed, then I feel that you have to reconstruct bone with bone. Unless one circumstance. The one circumstance is a person with a very large Hill-Sachs defect. So this is a patient of mine, 24 years old, substantial glenoid bone loss, substantial Hill-Sachs defect. what I did for him is I did just the Latarjet procedure. So you can see the image on the left right here. There's his Latarjet. And what I left is I didn't feel like I needed to do anything for the Hill-Sachs defect, because we know that a Latarjet is an effective management for Hill-Sachs defect. However, at 1.5 years after his Latarjet, he dislocated again. And so I looked and got a CT scan, and his Latarjet had healed. So the only operation that I felt I should do in him is another soft tissue. And so what I did do is a remplissage. So here was his Latarjet screws. So I put in 2 metallic screws right here, suture anchors, and I did a remplissage procedure. And he's now 7 years post-revision remplissage for recurrent instability after Latarjet, and he's been stable. So this is the rare indication to do a soft tissue procedure after Latarjet, and in the real instances, it's something that I've missed. And I agree with Dr. Himat that if you miss the pathology, you may have a greater risk, and I missed the pathology here. And so in general, if you have a bone problem, I feel with the Latarjet, you have to reconstruct it with bone. So my preference for revision of a failed Latarjet is distal clavicle autograft in a younger male patient that has good quality distal clavicle bone. With a distal clavicle, you can only reconstruct about 20%. Then there's iliac crest autograft for greater, that's my second option. And my final option, which I do very limited, I don't have a lot of experience with it because I don't particularly like allograft, is distal tibial allograft. So with distal clavicle, there's some advantages. It's locally available, it's autographed, and it has relative good articular cartilage on it. But the disadvantages are it only reconstructs about 20% of the glenoid, and there's a question about bone density, especially in female patients. The bone of the distal clavicle may be osteopenic. And most patients have some degree of osteoarthritis in the AC joint. However, that's why I preserve this operation for younger patients. So this is a patient of mine, a 22-year-old patient I did an arthroscopic Latarjet on, as you can see here. He's a professional hockey player, ice hockey player, which is a contact collision sports. And against medical advice, he went back to surgery too quickly. As you can see here, he fractured his hardware and developed recurrent instability. So in him, I indicated him for a revision procedure, which was a distal clavicle. And so I'm harvesting the distal clavicle graft here. I take 15 millimeters from medial to lateral, and I use this sort of arthroscopic Latarjet system. There's the graft. So it's about 15 millimeters thick on the articular side, as you can see here in the bottom right image. And then I secure it to the pistol grip guide here. And the premise is I'm going to secure my distal clavicle and fix it with 2 screws, as you can see here. Now let's go ahead to surgery. So in this patient, they had their failed Latarjet with fractured hardware. So I'm going to spend some time exposing the glenoid vault. And believe it or not, hardware removal is hard. I think that's why we call it hardware. And to take out hardware is always challenging. You can never predict how long it's going to take. We always think it's going to go very quickly, but it can take some time, especially if hardware is bent or if it's fractured. So I'm just marking the position between 2 and 5 o'clock where I'd like to place the distal clavicle autograft. But there I am still taking out the hardware. There I find some more screws, and they're all scarred in because it's titanium screws. They get scarred in with the soft tissue. And we'll spend some time taking that out. There it is there. And give it a tug. I promise it's going to come soon. And come on. And there it comes. So now there's my distal clavicle autograft. There's a 2 o'clock mark right there. And I've pinned the graft there. And just like with the Latarjet, I took out the pins and put in 2 cannulated screws. And there you can see the distal clavicle autograft on the left. And you can see it has articular cartilage on it, which is, it does have some benefits. So hopefully it decreases the risk of arthritis, because now I need the humeral head to sit on the graft. Because I failed the Latarjet, this graft has to be structural and both functional. Now, distal tibial allograft is also something that I have used. I used it very rarely. This is a patient that was referred in for a failed Latarjet. There's the failed Latarjet. I used an open distal tibial allograft technique. There's the graft. And here is the prepared glenoid. I took out the prior screws. I was able to actually dissect out the conjoint tendon. I usually don't do that, but in this case, we found the conjoint tendon and the distal and the coracoid tip right there. And now here is the distal tibial allograft. And what I did is, because I was lucky and I found the coracoid tip, which usually is very difficult to find, I do not recommend trying to look for it because I think there's a risk to the axillary nerve. In this one case, I found it easily, but I don't recommend it, is I actually incorporated it into the distal tibial. So here's the distal tibia, and here's the native coracoid, which I also put in with the screw right there. So rarely, I also use humeral head allograft. So this is a patient here at a failed Latarjet, large Hill-Sachs defect. You can see quite large, failed a Bankart remplissage, failed a Latarjet. And so what I did in him is I did a humeral head allograft reconstruction, as you can see here. And then I also did a distal clavicle. So I took his distal clavicle, put it down here, and turned it sideways. So he had humeral head reconstruction and glenoid reconstruction. And this is him at 1 year follow-up. You can see that it's still partially there. I would expect that it is going to resorb, or partially going to resorb. His distal clavicle is still there, and he's still stable at 1 year. So actually, I've now seen him at 2 years, and he's still stable. So hopefully he stays stable. So in general, there's also something that I call recurrence plus. When you have a Latarjet problem, but the joint is arthritic and damaged, or there's persistent subluxation and dislocation, or there's nerve injury. And these are the bad ones. When this happens, it's always a challenge. So this is a 27-year-old male patient. He was referred in for a failed Latarjet. He has instability. Unfortunately, after surgery, the axillary nerve was damaged, so he had an axillary nerve injury. And unfortunately, the surgeon chose not to operate quickly, and it chose to watch him. And so you can see what's happened is he had persistent subluxation, and now with the prominent hardware, he's eroded into his humeral head. At the age of 27, with post-traumatic arthritis and an axillary nerve injury that's failed, so a plexus surgeon tried to graft the nerve, and then the radial didn't work. There's only one operation for me, and I offered him a fusion at 27, and that's what I did. He's not happy, but he's better than he was before. He says his shoulder's not normal, but for the first time, he has no pain. And so he's 3 years out, and he's satisfied. Recurrence plus, look at this patient. Another failed Latarjet, loose hardware, bone destruction, shoulders chronically subluxated. This patient's older, she's got instability, she's got arthritis. In the workup of a failed Latarjet that was done open, I always get an MRI to see what the fat quality of the subscapularis is, and this patient had high-grade fat infiltration, indicating that they had a subscap failure. So still in North America, many times when surgeons do a Latarjet, they actually partially detach the upper half of the subscap, which is okay, but then there's a higher risk of subscap problems. And so this patient, the only thing that I could do for her that was predictable was a reverse. So when Latarjets go bad, it can be challenging. So when you have the failed Latarjet, in general, management with a revision soft tissue is rare. It's usually going to be bone for bone. I prefer distal clavicle iliac crest much more than allograft. And then the recurrence plus, which you have to manage each patient individually. There's no standard protocol when you have a recurrence plus, because they all have unique different problems. They have nerve injuries. You may be able to manage them with a nerve reconstructive surgery, hemiarthroplasty, reverse shoulder, or worst case scenarios, a fusion in a young person. So a very sobering way to end the talks. And that's what I was going to share with you today. And we're almost on time. Wow. I'm happy to take any questions if there are any questions. I think Dr. Ruprasad, you're muted.
Yeah, sorry for that. There are some questions from the audience. Open letter okay, that's not the one. So as we know, the instability usually is painless. And instability is quite painful. I don't know why he has written painless. So what is your approach for painful shoulder post-op lateral J, whether it is failed or not failed?
Yes. So in patients that have constant pain before surgery, I'm very nervous about them because instability hurts when your shoulder is dislocated, but it shouldn't hurt when you're resting. So I'm always nervous about those. So I warn them they're going to have a higher chance of pain after I do their stabilization surgery. But if they have pain and the lateral J was done well, then I try to investigate, why do they have pain? Do they have problems with infection? Do they have nerve irritation? Do they have hardware irritation where the screw is too long and irritating the suprascapular nerve? Is there a non-union? Is there a malunion where the graft is too proud? Or are the screws too oblique and eroding against the humeral head? So I start to think of all those, the list of problems, and I start to investigate all of them. And then rarely you're gonna have a patient, and this happens to us all, where everything you've checked is normal. You've done everything and they still have pain. I offer them a hardware removal. And if they're still painful after that, I must admit, I don't have a solution for those, but those are very, very rare. I think the majority of patients do quite well after this operation, but you have to be prepared. Like with any operation that we do, we have patients that have some degree of residual pain that we can't figure out why they have it. That same thing happens with the lateral J.
Dr. Jad, there is one more question. I just, on behalf of our country, which is quite poor, and all sorts of doctors are there and patients are there. We do use, some of us who are practicing in the major cities, we do use these nice screws which are manufactured by these companies. And for the lateral J, what I'm talking. So, but in the remote places, they obviously can't afford because they're expensive. And can this be done with the 3.5 screw system and cancellous, partially threaded?
The open or
open.
I think with open, if a surgeon feels comfortable, they may not even need cannulated. I think you can put the guide or K wires in to make sure you're happy, and then drill with the cannulated drill, take the cannulation out, and then use a solid screw. Because I personally think if the screw has to be, if it's cannulated, they have to be bigger to be solid. And in the 3.5s, I sometimes worry in a bigger person, it may not be enough. So I like to use a solid screw. So I'll just use, you can still use all the cannulated system, but then put a solid screw in if you're doing it open. Yeah, I think that's fine as long as you get good compression and you prepared the graft well. And in a smaller patient, shouldn't be a problem.
Dr. George, how often do you assess the axillary nerve by nerve conduction study before you go for a revision?
Only if there is a physical exam feature that leads me to believe that there's an axillary nerve problem. So if they have atrophy of the deltoid or their weakness or they have pain that I can't explain, then I'll consider EMG and nerve conduction studies. But only if they're on history or physical examination leads me to that. I don't do it routinely.
Okay.
There is a question from the audience. Dr. Karim is asking, 35 to 40-year-old, failed instability surgery, soft tissue or bone, hyperlax and subluxated voluntarily. So you want to choose the fusion or reverse shoulder arthroplasty?
How old was the patient?
35 to 40.
So with voluntary instability. Those are patients I spend more time with. I have to understand them better because, so with hyperlaxity and voluntary instability of the glenohumeral joint, they may still develop the same with a reverse. They still may dislocate, and they may, with a fusion, you will successfully solve their glenohumeral instability. But if a patient's voluntary and you fuse their glenohumeral joint, sometimes those patients develop really bad scapular winging. Like they start to play with the scapula, and the scapulothoracic joint causes pain. So I go very conservative with those. I try to do rehab with it. I try to figure out why they're having this voluntary instability. I'm very cautious in going to surgery with them, which is very difficult because they come to us wanting surgery. But you have to be very careful stabilizing the glenohumeral joint, fusing it, because then they may get scapulothoracic instability, which is awful to treat. There's no one correct treatment pathway for that patient. That's a patient that it's an individualized treatment that I have to spend time with them to learn how I can help them.
Yeah, thank you. George, you showed one X-ray where you have done a fusion. You're an arthroscopy and arthroplasty surgeon. How did you choose that? Was that shoulder conservable in terms of arthroplasty or something with so many options?
In this patient, I didn't think it was because they had no axillary nerve. So is 27, instability, no axillary nerve. They'd already failed nerve grafting and failed nerve surgery. So you could do a pec major tendon transfer to reconstruct the deltoid and then a reverse. But I talked to him about that. He said he wanted something that was predictable. And so for me, a fusion is predictable. I know it seems like a lot, but this is what he had. So when you manage people with failures,
yes,
there's no one way.
I understand. Yeah. Thank you so much.
All right.
There is a one question.
Yeah, Dr. Naveen.
There is a one question from the audience. Dr. Sajad Ali, can it be fixed with the cortical screw? That is his question. The screw.
Oh, yeah. I don't see why not. As long as you, if it's going to fix it with a cortical screw, then you have to go bicortical. And then if you go bicortical, you don't want to go too long because you're going to be close to the suprascapular nerve. So I think bicortical is absolutely fine. Just have to be very cognizant of screw length or orientation. So you want it to be very parallel to the glenoid. So you're not going to go towards the suprascapular notch or the spinal glenoid notch, pardon me. All right. I should probably get going. I have to go to the operating room.
Okay. Dr. Avinash, are you there? Just a minute.
Dr. Hemant sir will do the vote of thanks.
Yeah, Hemant, you can just conclude the session.
All right.
Thank you.
Thank you so much.
Good evening, all. And first of all, we should thank the BOS, Dr. Madan Ballal, Dr. Avinash, Dr. Uday Kumar sir, Dr. Satyavamshi, Dr. Naveen Thakkar sir, and Dr. Uday Prasad, Dr. Chaitan Nagaraj for presiding over the program. And I think we should be very grateful for Dr. George to spare his time for us and sharing the academic extravaganza. It's not a simple thing to revise a Latarje. So those who do, they know that how difficult it is and how challenging it is. And to share his learning curve, it is more important for the younger generation. Nothing comes straight to the hands of a young surgeon. Researchers like George put a lot of effort, take a lot of complications so that they simplify the procedure and give it to us. And